Hello. Okay, guys. I'm sorry to be a little late. You can tell from my hair, it's been a little bit of a rough morning over here. But anyway, it is nice to be here with you guys now. It'll take me a second to settle in. So today's thingamajigger, we have, some of you will have seen before, or the subject, we've addressed the subject last year sometime. For some of you it will be new, some of it will not, but there's such juicy stuff. There should be plenty in here for everybody. So a reminder of these things, guys, this is safe space, especially with an intimate subject like this. So, we should be able to say and feel and think just about anything in here. Everyone, you're welcome to participate. We'll go through some slides, just get some level setting, and then we'll kick it up into conversation and questions and back and forth. All right, guys. Happy New Year, by the way. I suppose it's our first webinar since in the new year. So Happy New Year, everybody. And I am really, despite my hair, I am very glad you guys are with us. Okay, over to you, Sonia.
Thank you, BJ. Hi, everyone. Thanks so much for being here this morning on a Friday. Just wanted to give you an update on how you can interact with us after BJ has gone through the kind of overview of the topic. So you can raise your hand and we will unmute you and you can ask your question out loud, or you can type into the Q&A area and I will read your question out loud for BJ to answer. So two options: raise your hands, ask out loud, or if you prefer to not speak out loud, you can just type it into the Q&A and I'll read it out for you. And just another note, if we are not able to get to all the questions and answers by the end of the hour, we will record a second session with those questions that we didn't get to. So please know that if we're not able to address it within this hour, we will do it afterwards and we post that recording along with the full one. Thanks again for being here.
Thank you, Sonia. And I think, guys, this is our first webinar on Zoom, maybe. I think we used to be.
It is. Yep.
Yeah. So for returning folks, it's a little bit of a different interface, just to call that out, unless you feel a little crazy.
And to add to that, this is our first Zoom webinar. So if anything goes a little wonky, please bear with us as we get used to our new controls, and thanks for your patience.
Right on. Okay. All right, well, let's jump into what may be the sexiest topic we ever discuss. Okay, so one thing, illness changes everything, many things. Caregiving does, the whole dynamic changes. And as far as intimacy, sexuality, sensuality, is a connection between people and things, between people and people. It's a dynamic. And so roles change, the dynamic changes. And for some of you, some of us, sex is something, or sexuality is something you can take for granted. It's sort of this ever stewing thing that's always there and accessible. But for many of us, it's not so accessible, even when we're well. It's a loaded thing, and it's a very, I think a lot of sex experts, which I'm not, would tell us that sex is, 80, 90% in the head. So of course, changing roles, going from husband to patient, or wife to caregiver, for example, or vice versa. And I don't mean to be stuck on husband and wife, by the way, guys, we're wide open here, but for shorthand, I'll just say something like that every now and again. So you can imagine, though, as those roles change, the dynamic change, and therefore the laws of attraction shift. What used to do it for you guys may not now. So I don't think we could say too much about this. This is a very sensitive shift. And so as you move through these new roles, one, you kind of have to give yourself time to catch up and be into these roles and settle into being caregiver and spouse or partner, for example. And it takes a while, and it takes some creative thinking. Oftentimes, sexuality, physical intimacy shifts insofar as what used to do it for you may not now, but what used to maybe not do it for you can now. So just things move. So you got to kind of find a way to roll with it. You can imagine communication is super, super key, as is not getting down on yourself. That's golly, that's a libido killer. And so here again, so easy to do when we're feeling vulnerable and in a new role and don't really know how to behave, etc. Of course, there's the change in bodies. Whether all of a sudden you've landed yourself with an ostomy bag or missing limbs or, who knows what. Radiation burns. I mean, I should probably even not start the list. The list is very long. But suffice to say, our bodies are different too as we go through illness. And so here too, your nervous system is different. You may be numb where you're used to what used to be very erogenous, and it may not be numb or even painful. I think the key is not getting down on yourself about that's not your fault. It's just the way the body's going, but also, and also to look elsewhere, to revisit the body now, sort of fresh eyes and fresh hands, and fresh everything, and explore. Again, new places might light up. You may need to kind of get in touch with a much subtler sensation. All sorts of things. The idea here is to be kind of wide open and to drop one of the killers is, well, I used to do this. It used to be that. I mean, that may be a nice jumping off point, a point to return to try, but try very hard to give yourself the credit and the space to be in a new place now. And so the old tape may not serve you at all. In fact, oftentimes it becomes this thing to beat ourselves up with. So be cautious, be light if you can, be a newborn. That may goes with this image. It may feel funny in a talk about sexuality, but we'll talk about this later on. But sexuality here, guys, let's be clear. We're not talking about intercourse per se, conventional sexuality. We're talking about the body being a source of pleasure and connection in its own right, in its own ways. So back to changing bodies. Yeah, just try your best to roll with it. And that may take some time. You may need to grieve the old body being gone, etc. So patience. And I wouldn't try to hop right to full-on intercourse. It may just be holding each other, touching each other's elbows. Find some place it doesn't hurt. That's part of the trick. Similar staying with this body of yours. It kind of goes with what I was just saying a moment ago. Move with it. You are different now. This is a different place, a different body. I think you'll go farther treating it as though you just landed in a new body, kind of almost in some sci-fi kind of way. That'll give you're more apt to give yourself the appropriate sort of innocence in a way. And staying with your body, another way to say that, of course, would be to love this body. Find a way to keep loving this body. It's going through so much. It can therefore be a source of frustration. It's a little bit of what's happening with me this morning, actually. And so we're trying to talk about this body being a source of pleasure when this thing is just annoying us and 10 steps behind us or 20 steps ahead of us or whatever it is, being so out of sync with these clunky bodies, especially as they're shifting, especially the neurons are screaming. So staying with your body, no way of saying that's loving your body and moving with it and feeling for it. And self-compassion is a good phrase here too. So it gets all these little snares, these hang-ups, like I was saying earlier, I used to be this, I used to feel that, I used to be able to do this or that, or I had this prowess, mourn that, keep on moving. I love this image. As usual, it's just the images are courtesy of Sonia, by the way, guys. Thank her. So beautiful. You're so good. Okay, but this is where so much of the action really is daring to go uncomfortable places. As I mentioned earlier, communication is so key to navigating these waters. Usually verbal, but a lot of eye contact, checking in. So communication is super, super key. See if you can find a way to make that part of the erogeny, part of the connection, part of the desire. It's really, can be a kind of a joy of cracking the plane of difficult conversations. It's charged but you can get the same kind of nervousnesses and butterflies as you would about on a first date. But I push you because for all the reasons we've already said, these changes are just, they happen with illness, old age, disability, end of life. All of this is just variations on inevitable themes. So no shame in being where you are, although it can sort of feel like that. Part of trick two, part of what makes this difficult is I would imagine a lot of us who have found our way moving through the medical system, we doctors generally aren't very good unless we're there expressly for to deal with sexual organs or something. But even then we're clunky. I've heard some outrageous stories of just sort of divorcing the body from all its import and so much of its poignancy and meaning and talking about it in a rough way. And it's not uncommon that people have gynecological surgeries, women have gynecological surgeries, or men neurological surgeries. It's not uncommon that the doctor may have barely mentioned sexual side effects. And oftentimes they won't ask about how your sex life is going. Sometimes they do, but it's just another one of those things that's really not on most doctors' lists for whatever reason. So sometimes if you're wondering if it's safe to have sex, you maybe need to be the one to push it with a doctor or the nurse and ask about it. So the uncomfortable conversations may start with your doctor. Is it safe? Can I have sex? And again, you might need to be the one to push that conversation. And sometimes if you find yourself, by the way, like in a room with medical students and a team of people, and it just seems like the last place you'd ever want to talk about something, it's totally okay, by the way, to say, hey, doc, can I talk with you alone? I've got it just for a couple minutes or something, something intimate or private I'd like to discuss. It's completely okay. If a doctor looks at you slanted, like, push back. That's a completely reasonable request. So that's one piece of this puzzle, but the bigger piece of the puzzle is between you and your partner or partners. What helps, what hurts, what doesn't, what feels good. It may not, navigating the body may no longer be so intuitive. So back to communication. And again, see if you can find a way to make it part of the action in a way. I may be asking too much, but one way or another, put yourself through it. Get to that. This is where the intimacy really begins, of course. And you'll also free up your partner who's probably worried about hurting you or not doing the right thing, etc. So feedback, real time if you can. So, thank you. So speaking of uncomfortable conversations, there is, it's interesting. Sensation is like a spectrum, right? I mean, we need friction to feel anything. And I don't just mean in the sexual organ way, I just mean in life. If we don't have friction, if we're not rubbing up against something that's a little bit different, or it's a little bit of a contrast, we feel nothing. So it's kind of interesting to realize that we're always in some frictions where it's at, and that can get very coarse. And the friction can be emotional. The gap between two people can be rubbing each other wrong. That can be a comment about flesh. But there's a dynamic, certainly, where it's too much, it's too uncomfortable, too much friction. Dynamic where there's not enough friction, where it's just too much ease. And I mean this metaphorically, conversationally, rhetorically, physically. So we're always on this particularly with intimacy, we're always kind of towing this line, perhaps exquisitely, between comfort and discomfort. And so it goes here. So you're just kind of changing up the ratios and rewiring that kind of the phenomenon. You're rewiring the amount of friction and where the friction is. So I realize I'm stepping all over a bunch of metaphors, kind of on purpose, kind of not. But the bottom line here, guys, is discomfort is okay. It's part of the deal. In fact, it may be an essential part of the deal to some degree. So play off it, work it. I remember I think I referenced this last time we talked about this together. I should have looked it up. There's a film I saw. It's like Bob, Super Masochist, something like this. And it was like a serious art film documentary. It was beautiful. It was really fascinating. I saw it long, long ago when I was younger, and it really stayed with me. is a man who had cystic fibrosis, which incurs a lot of physical discomfort. Generally speaking, a shorter lifespan, all sorts of stuff goes with cystic fibrosis. It is not an easy one. And it comes with lots of excess mucus production, thick mucus, not what you most would consider a sexy diagnosis by any stretch. But Bob found a way to go into his pain. He became a super masochist, but you went to extremes. But the point is, as a young man, he realized that pain was going to be his companion with this diagnosis. And so he brought it into what he played with, what he worked with. And by developing a sexual vocabulary around it, he came to terms with his situation by working it, by using that pain, by seeing what he could take, by pushing himself. He turned pain into something erogenous. That may be asking way too much for many of us, but maybe you take the point. The extreme makes the point here. So discomfort, again, nothing to shun there. That's part of the deal. But see if you can play with the systole, diastole, the contrast, the in, the out. Oh gosh, I'm really getting off with metaphors. Sorry, but I think maybe I'm making a little bit of sense. Okay, let me keep moving with our slides here, guys. Being alone. So here I am. This happens so often. I apologize, guys. I'm always talking like, everyone's got family, everyone's got partners, everyone, got friends. I often presume that in the way I talk. It's caregivers, etc. And my apologies. The truth is, many of us are very much alone. There's no partner, there's no spouse, etc. So there's much to say about this. That doesn't mean you're not a sexual being, of course. It certainly doesn't mean that you're a being without connections, which we'll talk about in a minute. But I just want to make some space for this idea of being alone. And I guess I'd encourage anyone who meets that description, or when any of us meets that description, because probably all of us feel that way sometime. It may be a nice invitation to go inward. And this may take the form, in the talk about sexuality, that could be, that could be, masturbation. Let's just use the M word. I think we're all adults here. That masturbation happens. So this may be a very important thing to do for stretches of being alone, to stay connected to yourself, to your own body. It's amazing the body can just start, we can get removed, distant from ourselves. It seems like a riddle, but we can. And the neurons get dulled, and our exquisite receptivity can get dulled. So on the sexual plane, I guess I'd encourage any of us to not let sex end just because we're alone. And also just to let that be its own sort of point of connection. And here's what I mean by that. So let's back up and let's get underneath the point of this conversation today. So again, I think I said it earlier, but sexual intercourse is not the point. For some of us, it may be where it's at. But for plenty of us, it's never where it's at, never mind when we're sick. It's another one of those false presumptions that we hold. Everyone just wants to get laid all the time. No, that is not true. And a lot of people mean very different things about getting laid. So I think when you strip it down, if sex is this thing that allows you to be in your body, to be present with your body, to bring holiness, it can be sacred. There are all sorts of spiritual traditions around the sexual act. So there's much to say about it. It can be a holy thing, a gorgeous thing. It can also be very fraught. But the point is, if sex is pulling us into our bodies, well, then maybe the point is to feel things. So then maybe the point is sensuality or sensuousness. I like that. It takes out the sort of pressure of performance that a lot of people, that gets roped into sex per se. But sensuousness, sensuality, less of a performance, just more of a feeling. So whether you're alone or with people or whatever, I would say, and if sex just seems out of reach, as we say in our book, A Beginner's Guide to the End, screw sex or screw intercourse. It's not all that for everybody. So let's just start. Let's get back to just feeling something in real time, letting our senses light up, even subtly. It can be kind of fun with illness to see how subtle you can get your signaling. Be really exquisite. So if feeling is the point, well, great. That seems much more accessible. And so why might we want to feel things? Well, to be in our body, delight in being at all. And being is generally felt through connection. So I think the bottom line that we're going through here, guys, is basically connection. And who's to say where you get to feel connected, whether you're alone or partnered or live with 30 people, whatever it is. Uh, Connection, that's yours to say. I remember the story that comes to mind from my clinical life was a man who was a patient of mine for a long time. And he was he was very grumpy. And he, by his own admission, he was not a warm, cuddly person. People just seemed to flee him. Every time he was in the clinic, there would be complaints from the nurses, from other patients. It was profound. He really struggled on the social plane. He would tell you that. I don't mean in any disrespect. This was out. But as we got to know each other, he ended up being one of the more tender people I ever ended up knowing. In human connection was just too much for him. He couldn't handle it. It was so overwhelming. It was the opposite of subtle. It was just like I don't know what the analogy is. I'm screwing up analogies today, but for him, it turned out his connection, the way he felt in his body was through his camera. And so he'd walk the streets of San Francisco and taking pictures of intimate settings, intimate scenes on the streets with people. And he brought his images in to show me one day. And it was just amazing to see. They were so beautiful and so lush and warm. Excuse me, so much of the opposite of what he appeared to be outwardly. But for him, that connection was still accessible. It just required a camera. That was his thing. That was the way he lit up. So my point here is connection can come in many, many forms. Start with what's actually working, where you actually feel connected. Hunt for that first and build on that, versus finding your thought of saying, well, this should make me feel good. This should make me feel connected, or it used to make me feel connected, and therefore I'll go with that. Meanwhile, your body's saying, no. So go with your body. Go with the sensation. See where that takes you. Okay. I think I'm making sense a little bit here, guys. So we've kind of gotten at this already, that sex in a way is the most rarefied point of physical connection. The most pressured, the most exotic, the most rarefied. Lovely, but sometimes out of reach. So then let's bring it down into this sort of sensual and sensuousness. Remember, there is a difference between sensual and sensuous, but I can't remember what it is. So I will look it up after we hang up together. But I think one has a more sort of sexual implication or sexy implication. One is just neutral, just feeling anything, like a baby could be sensuous. I think that's a distinction. I don't think you would find a baby acting sensually. Sensuous, yes. Again, excuse me if I'm getting this wrong, but the point here, guys, is, and thank you for sticking with me so far, is to pull it out of, make it as accessible as possible, as easy as possible, as a portal of entry into your body, into the body of a partner, whatever it is. Go where the feeling is, just take the charge down, take the meaning down. Don't wind it up, don't layer it up, don't load it up. And if you find it is loaded up, no matter what you do, well, then there's probably some crying to do. Which, by the way, guys, is a very intimate act. So that sensuous or sexual encounter with a partner might turn out to be just spooning, just lying together, weeping. I don't know that any of us would consider that a sexy experience. Maybe some of us would, but the point is, it sure is connected. It sure is intimate, and it sure is sensuous. And then you can build from there. Ooh, okay. So let's see how we're doing on time. Oh, okay. So I'm going to pop us out of slides, guys, and then let's move on to the fun stuff. Conversation together.
Just want to add here, someone wrote in that sensual is the one that is related to sexual, and sensuous is related to the senses instead of the intellect without that sexual connection. So I think you had it right.
Great. Hey,
Yeah.
yay me. I'm feeling sexy.
So we did have one question come in while you were speaking. This person said, as a palliative social work student, I feel like this is a subject that your average medical team member will not naturally and gracefully address with patients. I want to build muscle in this area. I know always developing ease with my own sexuality will help, but what is your best advice for bringing this subject up with patients and or their partners?
Oh, God, I love you for asking this question. I love you for going to social work. I love you for asking this question and thinking about it in advance. It's so good. So you named one, which is, so much on this sort of emotional and spiritual planes that happen in the clinical world. If it's happened at all, it happens because you as the provider are paying attention to yourself in some way. You're using your body as its own antenna and radar and feeling with your patients. And yeah, so you're onto something, my friend. So first of all, of course, it's addressing your own sexuality, your own hangups, your own neuroses, being wide-eyed about yourself in the world. That's job number one. And no, job number one, I don't know, whatever. It's an important job. So otherwise, on top of that, in addition, with all that sort of attunement, um, practice one thing I would point you to is practice your gut sense. What is your gut telling you about this patient? Because very rarely it will happen, but I would imagine it'll be rare that a client or a patient will come and say, "Hi, person, I want to talk to you about sex." It happens when a patient does that with me. I love it. It's just, I'm so proud of them for advocating for themselves in this uncomfortable environment. Um, so one would be for you to kind of use your attunement and see if your gut sense is right. That gut and intuition is bodily, it's more aesthetic, it's more related to the senses. That instrument, tune that instrument. And the way you check it is as you get to know your clients and patients, you can say, you don't have to, you can just simply say, "Hey, would it be, I notice X, Y, or Z when we were talking in the appointment about bodily functions, or we were talking about pelvic pain, um, or you mentioned the word loneliness. Look for the little clues to ping off of them, so it's not a generic offering. Pull from what they're showing you or telling you, and you can say, "Hey, I noticed this. Would there be? Is there something more to talk about there? I have a sense that maybe there's more to talk about there, and we can shut the door. And this is a safe place, and our conversations are protected. As a way to start." Or you can go right to, I know from experience, a lot of people who've had X, Y, and Z condition, one of the first things to suffer is their sex life. Just want to check in with you. Is that something is that up for you in your life? Because if it is, that's very common, totally normal. And should be a safe place to talk about it. So I'm here if you'd like. These kinds of things. It's sort of, you're pinging off of them, kind of approaching gingerly, knowing it's a fraught subject. Oftentimes, I bet you'll meet people in your career who the second you mention the word sex or even acknowledge loneliness, tears will start flowing immediately because they'll be so glad someone finally asked them about this. It becomes kind of cruel how we ignore this huge chunk of a person's life. So no big deal. When we're talking cancer, sex, who cares about sex? Well, quite the opposite. If we're talking about cancer, then we're really talking about sex. It's finding some way to be in our bodies, getting even harder. So you're right to say the medical system you're going to take this one on yourself. I bet you won't get much training in it, but this is sort of the way you do it. Ask permission. "Hey, I noticed this. Hey, would it be cool if I talked to you about this or that?" Just don't bludgeon anybody. You don't have to force anything. And oftentimes it may take a couple visits. So maybe you set the trust in place early on in that first 2 or 3 visits. Just get to know each other, make sure they feel comfortable, share your name, share a little bit about yourself, get the relationship going. And then when it feels right, or when there's clear need, then you're ready to discuss it. The other thing to do would be to keep in mind what resources exist in your community. Sexual surrogates is a real profession now. So there can be you can pay licensed therapists to engage in the sexual act to help coach one back into sexuality, or one to sexuality in the first place. So sexual surrogates, kink, like Good Vibrations is a store here in the Bay Area. It's all over the country now, I think, where they've sort of normalized the sexual act. It's like walking into the public library. There's no crazy charge. It's not red lights, not smoke filled. But places like that, talking very openly about sex toys, for men who have prostate issues, like just getting the blood flow, masturbation, touch, prostate massage, all sorts of things that sound kind of kinky are actually kind of medically just good for you, getting the blood going. So being aware to point people for gear, for stuff, that's a nice thing to be armed with. Perhaps there's support groups. Perhaps there's a sex therapist or someone in the health system who specializes in sexuality. Keep an eye out for that too. So amassing yourself with local resources. So once you broach a subject, you have something more also to point them to, would be great. But I think the big therapeutic value is you just daring to be there with them and talked with them about it, and maybe even touch their arm or something during that encounter, just getting us back to the body. The fact that you're paying attention to that will itself be so therapeutic for them. So right on. I'm so grateful for that impulse in you already. Thank you.
Okay, we had another question come in. This person said, I have cancer and I am single, but I like having someone in my life. Have you ever had a patient who was trying to date or find a new partner while dealing with a serious illness? How did they handle it?
Wait, can you read that back again, sweetheart? I'm sorry, Sonia.
Yeah, no problem. So this person said they have cancer and are single, but they like having a partner in their life. Have you ever had any patients who are trying to date or find a new partner while dealing with a serious illness, and how did they handle it?
Yeah, that's a couple folks I've gotten to work with over the years come to mind. Absolutely. You know, there are a couple approaches, of course. You don't have to disclose cancer to anybody, or it's your body. It's when it feels right. It's hard to imagine a real full relationship without eventually sharing such news. But even as I say that, that's an opinion. So one is it's yours to disclose. Let that be an intimate act, by the way. Some of us, I mean, that is a trusting thing to disclose. Some of us with our disabilities, I just live. There's nothing to disclose. It's already disclosed. But just to say, to start for you, don't feel pressured to tell anybody about cancer. So an approach might be to get to know someone, not disclose that, and when it feels right, then bring it up and see. I think a lot of people I end up talking to take a slightly different tack of putting it out there quickly, because some people will fall away, some people will be attracted to it. Believe me, there will be some ghoulishly, perhaps, but some folks just know, oh, here's a real person going through something real. I like real people. That's true too. So maybe the question isn't so much whether to disclose, but how to disclose and when to disclose. And here again, like so much of this stuff, find a way to getting right with it yourself first, as right as can be, because so much will flow from how you feel about yourself with cancer, how you feel about your body, how a lot will flow from that, of course. So key here would be to get as right with yourself as you can, and so that you're ready. And there may be rejection. Of course, there may be rejection based on the cancer or something else. Or there may be rejection because the person feels like you're not really loving yourself yet. And that might, who knows what's going to happen. But my point is here, not to foreshadow all that kind of stuff, but just if we're looking for intimacy and communication and closeness, see cancer as this piece of your intimacy. So see if you can work that and figure out a way to disclose it lovingly and confidently as possible. And we'll see where it goes. But bottom line is people with cancer find partners, all the time. All the time. I don't mean to make it sound so easy, but I think it's hard to find a partner, period. And cancer makes it a little bit more challenging, but it happens often. I recently knew a woman named Natalie who was on this project we were working on in Australia. She's late 20s. She met her partner after her diagnosis, before, and then she went into remission, and then the cancer came back metastatic. And she met her partner in the first phase, and she was terrified when the metastatic diagnosis came that he was, she was a goner, right? And so why would he want to be with her? She gave him the option, and he tearfully, beautifully said, "Are you kidding me? Like, whether we have a month or a decade or a century, I'm here because I love you, And it ended up being so much of their bond too. So anyway, yes, bottom line here is yes, finding a partner is absolutely possible. How you bring your cancer into that equation is entirely up to you. But I guess I would encourage you to find your way to seeing it as a piece of the intimacy. And if someone else can't handle it, I know this is the easiest thing to say, but the hardest thing to do, but I was going to say, so be it. Be grateful that you learned early that person wasn't right for you, because if it hadn't been the cancer now, it would have been something else later. You know what I mean? So um, um, I don't mean to be Pollyannish or over easy about this. It's not, it is challenging, but it's very doable. And I guess not only might you find a partner, but you might find an extraordinary partner, someone who can see much more creatively, much more expansively, has a worldview that can include your cancer. That's pretty damn sexy. So yes, I would encourage you to feel partnerable and get out there when you're ready.
Ooh, we have a hand up and it's Karen.
Oh,
Yay.
Karen, some of you guys might remember Karen joined us. We did this. I was in Utah. Karen joined us for a version of this talk last year. Karen is many, many things, guys. Karen Skanke is palliative care social worker. She was in rehab. She's a sex therapist. She's a psychotherapist. She is a one-woman dynamo. So anyway, Karen, can you, there you are. Hi, sweetheart. Were you going to say, was there a question, Mama?
Hold on, Karen, you might have to unmute yourself on your end. It's a two-step process. Okay, Karen's having Wi-Fi problems, so let's go to
Okay.
BJ, another BJ.
Ah.
BJ, you will probably have to unmute yourself on your end as well. There you are.
Hello there. It's
BJ, that BJ.
it's that BJ.
I know that voice. Hello, old friend.
Hi. I'm going to try to keep this very simple.
Okay.
Thank you very much for emphasizing that as we mature, as we age, and as we decline, it's so difficult to keep that juggle informed and balanced.
Mm-hmm.
It's particularly difficult when the complexities are multiple and each specialist may be heroic in the area he or she works in and be completely oblivious to other ramifications. So my question is for the caregiver as well as for the recipient, is there a way to be analytical and patient in dealing with the very known factors, the details of the diagnosis, therapy, etc., and the unknowns about the degree to which aging, gender, all the other conditions of life are equally, I think, important in trying to remain competent, sane, patient, impatient, whole. So walk us through a little bit about how, and I'll ask it as a patient, how can, when do I confront my caregiver with a very blunt criticism to say, you're telling me everything I need to know about liposarcoma, but you're not telling me anything about my aging process, how it fits into that picture. Does that make any sense?
Do you mean, I think so, Beach. Do you mean, are you saying, are you imagining you or I talking to a doctor or as our, or a friend or partner caregiver?
Uh, Not necessarily the doctor. So let's leave it at the more informal, less trained level.
Yeah. Well, so I hear that question. Amen, Beach. So nice to hear your voice. I mean, and this is so much the trick. It gets at, like we were talking earlier, about roles and changing bodies. And even the most dedicated caregiver or carer will be, like you say, focused on the liposarcoma or dish details or whatever it is, as an act of caring and concern and vigilance and wanting you to be well and wanting to tend to the things that are hurting and blah, blah. Yeah, that's gorgeous. Thank you. That is important. But what ends up happening, it's a version of what I think what I'm hearing you described. It's a version of what happens in the medical system all the time, where we've reduced part of the problem living with illness is you get reduced to your diagnosis. You get treated as your diagnosis. And it happens kind of benignly. It gets crowded out. You got 18 doctor appointments, it becomes a full-time job being a patient. There are some real concerns. So everyone's trying to hold these things and be careful. But what we end up doing accidentally and with good intentions is squeezing out all the reasons you'd want to be alive in the first place, in the name of helping to keep you alive. So we remove ourselves from the inspirations, the particulars of daily life, the neuroses that give us a personality, the sensations that make life worth it in the first place. So all this work goes into having a pulse. So little goes into why it's amazing to have a pulse in the first place. So if I take your question, Beej, as given all that, it often falls to a patient, the vulnerable one ostensibly, to say, hey, guys, much like you said, hey, I so appreciate the care and concern about X, Y, and Z. And you're right, I do have to do these things. And blah, blah. But what I really, really need is for you to help me hold space for the rest of life, all the poignancy of being a fleshy human being. That's where I get to feel, that's where living is. That's where I feel alive. And can you help me hold that space? We'll deal with the vigilance around the illness otherwise, or let the doctor worry about that or whatever else. So I don't know if I'm making sense here, Beach, but this I think is simply as simple and as hard as doing what you simply did with us here today, is just articulate it and couching it in love, of course, and appreciation, and not a charged thing if possible. But am I making sense, Beach? Does this seem possible? I mean, am I even answering the right question?
You make a lot of sense as usual. If I may just add two very quick personal suggestions. In my journey of the last 15 years, I found two resources that are marvelous. First of all, participating in a support group with patients similar to you. I happen to be in a support group for gay men's prostate survivor, blah, 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 blah. It's a huge relief to participate in a group with patients who have the same diagnosis, but we're all dissimilar. And the sharing we give to each other in our sessions is really rich. The second resource is that 3 or 4 years ago, several of my specialists would end each session by saying, well, is there anything else I can help you with? And I began to say, yes, I need a GP who is a specialist on gerontology because I'm getting damn old. And I want to be able to deal with a provider who understands clinically as well as experientially what it's like. And I got referred to one in the UCSF system who is simply wonderful. He's smart, he's knowledgeable, his bedside manager could not be better. And I'm able in my regular sessions with him that may just be dealing with an update about a particular chronology. He will ask me related questions about, well, what are you feeling about blah, 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 blah.
Mm.
It is such a relief to go to a clinical appointment that I am excited about going to, because there will be surprises and there will be totality. So I just
Mhm.
want to affirm that participating in a support group can be really meaningful, and also having someone who is a trained specialist in dealing with a part of your life that other people seem to be ignore. In my case, aging and gerontology.
Paige, thank you, thank you, thank you, thank you. I think that peer-to-peer thing is so important, and it can't be had with a doctor in a way. That there's something. Those are two, at least to my mind, the peer-to-peer thing is invaluable in its own power, and that relationship with your professional, with the provider, is also its own thing and invaluable and powerful. Um, let me just ask you a quick question on the follow-up. I know we got some other questions, but with this new GP that you mentioned, BJ, did you get lucky and land with one who just knows to ask these things, or did it, from your having been around the block, did you lead him to helping you in ways that would help? In other words, you know what I mean? Do you get some of the credit for advocating for yourself with him in such a way that he got to know you?
Principally the latter,
Mhm.
and also my relationship with the other medical specialists in my life. The trust I feel with my surgeons and all of the other folks, the trust I feel is I'm not going to be hesitant or shy about asking for anything, uh, because I know I will hear what I hear will be as close to reality as possible. So, in knowing that I had a vacuum in my medical resource life, I knew I had to talk about it. And in talking about it, it gave the recipient an opportunity to share their expertise. So it goes back to your principal question. A lot of this is all about communication.
And the relationship, it seems like you have to share, you have to give him a chance, and he's got to give you a chance. It sounds like you both you met each other. I wonder if that would have been different before all the medical odysseys you've been on. I wonder if that speaks to your being sort of a veteran in moving through that system one way or another. I'll just say I'm thrilled to hear you have that in place. That is a rare and beautiful thing to have a GP in your corner with whom you feel trust and seen and heard. That's beautiful. Makes me happy to hear, Beach. And thanks for sharing your poignancy and potency with us here today. I love how you move through the world and the health system, Beach. So anyway, thanks for sharing it with us here.
Thank you.
Thank you. Okay, Sonia, what else do we have going on?
Well, actually, Karen brought up a good point, which was just addressing sexuality in the world of COVID.
Uh-huh.
Any thoughts on that?
Oh, sorry. I thought that was the beginning of the statement. Oh, sexuality in the time of COVID. Woo, right. Well, I guess I don't have any invitation to the crowd to step in here on any of these fronts, but no, I don't have any brave thoughts except for maybe allows us to practice some of that sort of intimate self-intimacy is one, and to stay connected to ourselves while we're all quarantined up, or whatever, or removed. Another thing that comes to mind, excuse me, would be just the how erogyny can move. You know, maybe we're absent the sort of, there's so much poignancy that happens with the face in terms of expression and connection and feeling locked in with someone, and that's challenged by a mask. So obviously challenged by distance. So I guess one would be going inward. Another would be getting creative with, when you're able to be with another person, getting creative on how you touch, where you touch. Maybe if you have to keep distance, it may be an exercise in sort of intimate pillow talk. There may be an excuse to develop other points of connection besides sort of body on body. So those are some thoughts, but I'm just making stuff up here, guys, from my own experience. Please jump in with from anybody else's point of view.
And we did have another observation that I think is a really good one. This person said the loss of privacy that people with advanced age or serious illness experience also contributes to the loss of intimacy. My dad had ALS, and at one point he needed a paid caregiver in the home at all times. This made it especially hard for him to experience intimacy with anyone. In addition, caregivers often project their own discomfort onto the patient. Once my dad's caregiver spoke with me with disgust about overhearing a sexual conversation between my dad and a friend, as if this was something inappropriate.
Yeah. Yeah. You know, one tangent that comment brings up for me is, well, in health, in facilities, hospitals, any facility, just uh, again, tangent here is, but this is, you're not, intimacy is fundamental. This is, so if people are treating you like sexuality is some, or sensuality or bodily pleasure, bodily connection is somehow unimportant, well, politely or impolitely dismiss whatever they're telling you. This is big stuff, elemental. So one thing that people can do in facilities is close the door. You know, you can ask the nurse to put, you know, if a partner's visiting, you can put a note on the door, please check, visitors, please check in with nurse before entering the room. Put a little note on the door. It's not too much to ask. Just talk to the bedside nurse as an example. If you want to snuggle in bed in the hospital, that should be fine. Sometimes with tubes and things it may be problematic, but talk to your nurse, and barricade, build that safe, intimate space in your room for at least temporarily. But I don't think that really gets at your point. Sonia, can you read the second half of her comment or question?
Yeah, absolutely. She said, in addition, caregivers often project their own discomfort onto the patient. Once my dad's caregiver spoke with me with disgust about overhearing a sexual conversation between my dad and a friend, as if this was something inappropriate.
Okay, thank you. Yeah, my tangent was very much a tangent. So yeah, boy, that is, it's a version and sort of I don't know if it's a version of something that happens very often, where um, you may catch yourself doing. I do. I grew up with a mother who uses a wheelchair. I am disabled. You know, I'm as washed in this as can humanly be. And sometimes I too will make the mistake of talking, you know, through someone or past someone if they're using a wheelchair, and with someone who's ambulatory, for example. Or there's all sorts of ways we just sort of reflexively treat someone who's infirmed as less than. It's sort of stunning. It happens so easily that I've come to kind of feel like, gosh, on some level, this must be, I don't know what to make of it, but it's common, either in this very explicit way, like you're describing, which is obviously saddening and disappointing, disheartening, or subtle ways that we kind of be a little bit infantilizing or a little bit dismissive of the sick person. So, I mean, one thought is to just call it out. I mean, this may be hard. It depends on the dynamic with that caregiver. If we need that caregiver, there's no one else around, and that person is, you know, it's that person or no one. Well, that might change how you approach the conversation, but maybe not. I mean, this is very, very key. I wonder what it'd be like to say if you pulled that caregiver aside and say, you know, I just want to call you on something. When when you asked about, you seem to have a little bit of disgust on your face when you were talking about my dad talking about intimacy with someone. And just say, no, my dad's a human being. You know, he's got ALS, but he's a human being, and that's still part of his life. I want that to be part of life. Are you aware you were doing that? That may be asking a lot of you to kind of stick yourself in between that, into that dynamic. But it may be exactly, if you feel up to it, I'd push you to do that. That is not right. That's not okay. And you shouldn't just have to put up with it because we're in this sort of pity mode where when we're disabled or sick, we got to take any help we can get and be grateful for it, even if it sucks, you know. No, I think we need to sort of demand more and remind each other that these are human beings in the mix in both directions. Sometimes the needs of the caregiver get ignored. Often the patient's care issues get ignored. So back to communication, difficult communication, but this is a doozy. And if that caregiver is really interested in that work, doing that work, honestly, that you could be doing them a real favor by broaching this. She may not even know she's doing that. Again, these are biases that are deep, and people I see it oftentimes with myself. Sometimes when I'm wearing shorts and someone first notices my body, can sometimes pick up a very quick little repulsion. It may be pity or something like that, but it happens a lot. It's like a reflex. And so this person may not even know she's doing it. Anyway, back to communication. You are not, that is unacceptable. Your dad still gets to be a human being, and human beings are sensual, sensuous, and sexual. Okay. But please come back if I'm missing a gist of that question, or if you've tried that. There's a lot to perhaps talk about there.
The time remaining, we have another kind of comment here that I think is really interesting. This person said, one of the biggest challenges in assisted living or long-term care is intimacy for elders and family involvement. Adult children tend to think that their elder parent doesn't have that need anymore and will direct the facility to stop any relationships.
Yeah. Well, yeah, damn it. Stop that. I mean, like, this is, this is where there just needs to be some advocacy. I mean, again, these are the ways we die before we have to die. We don't allow ourselves to be sexual. We don't allow ourselves to laugh. We've got to be well behaved and shut up and take what we get in the corner, whatever it is. We just, the sort of turning of the screw, and you get less and less agency, less and less access again to the reasons why anyone would want to be alive in the name of being alive. So education, communication, advocacy, push back, talk to the nurse manager at that assisted living. So what are their expectations? Do they not allow dating among residents or sexual intimacy among residents? If they don't, I don't even know if that could be legal. I'd be very curious if the manager of the place had a policy around that. So push this, or be a little brash, shut the door. You know, are there locks on the door? Maybe, maybe not, but put a sign on the door. To the degree, I know this may be asking too much, but as with the last question, this may take an uncomfortable amount of advocacy. But this is a big problem. And of course, why would we want to be in nursing home and assisted living if we're just being systematically pulled away from the things that make living worthwhile? So try to upend that, communicate, try to push past that. And if the facility, you know, I'm trying to imagine where a facility would somehow remain obstinate on this point. Perhaps with COVID excuses. There was a nursing home not far from here who had a recent outbreak of chlamydia, you know, which I heard that I was like, all right, you know, great, people are doing stuff. Anyway, be curious if you're comfortable to come back and mention, have you tried anything? Have you talked to them? What did you hear back?
Okay, we are at the end of the hour, and I want to be respectful of everyone's time. If any of you who have asked a question have more information or want to share anything else, please feel free to email us anytime. The address is info@mettlehealth.com. So we'd love to hear if you have any additional information to add to what you've shared today. And thank you again so much for being here, and I hope everyone has a good weekend.
Yeah, thanks everybody. It's really good to be with you. Ciao for now.